for diagnosing children with Kawasaki disease, how we're working on developing a diagnostic test for Kawasaki disease, which I think is very crucial given the number of children that are missed or come to late diagnosis, as many of your own children have. Standard therapies that we give for Kawasaki disease, resistance to therapy, which many of your own children have suffered through, and what we're doing to try to overcome these issues. And then I'm going to speak a little bit about our clinical trial, which maybe even some of your own children have participated in, and we're eternally grateful for all of that. So this is a slide that I wanted to put up here, which, I really don't need to for the families that are here, but I think it's important for all of us to remember what our own children went through with this disease, and that it is a clinical diagnosis. And what we're left with as physicians, when Dr. Burns and I see your children in our clinics and in the hospital, is really being able to diagnose and differentiate this disease from other diseases that may look like it. So it's clear that there may be other diseases such as viral infections that can cause you to have redness of the eyes that may be confusing, lymph node swelling of the neck that may be confused with bacterial infection, redness of the tongue that could be confused with scarlet fever, and rashes also that can be confused with both bacterial as well as viral illnesses. So the challenges that we face as physicians when we see children with Kawasaki disease is to be able to differentiate those that have KD from those that do not. What helps us in this process, and the reason that we draw blood on these children and on your children, is that we really want to look for inflammation. And here we have inflammation of the gallbladder that happens, of the liver, of all the cells in the body that really help us. And it's putting that picture together of the clinical diagnosis along with the laboratories that put that information together to help us diagnose kids with Kawasaki disease. Unfortunately, as many of you know, it's not a perfect picture. And in your own children, you may have had your own child present with fever and maybe only a couple of the clinical signs. So what I'm going to talk to you about today is a little bit about the developing of a diagnostic test. So I'm very grateful to the Robert Wood Johnson Foundation for recent funding that is effective January 1st of 2010. That is a 4-year grant that will allow us to develop a diagnostic test for this disease. And the way this works is that with the samples that your own children have been able to donate to us, we'll be taking information from the serum samples from children with Kawasaki disease, comparing that to kids that come to the emergency room that are febrile, may look like they have KD, but in fact they do not. And then what we call healthy controls, which are children that come into the hospital and have blood drawn for another reason. They may be having an elective surgery done. And with all of that put together, what we're looking for are biomarkers or proteins that are specific for acute Kawasaki disease to be able to develop this diagnostic test. And it's really with this funding from the Robert Wood Johnson Foundation in collaboration with biostatisticians that we'll be able to put this information together. Our goal eventually will be to have what we call a point of service test, a test just like doing a rapid strep in your pediatrician's office that will be available in pediatrician's offices as well as in emergency rooms. So that when the child comes in with fever and rash, and there's a concern that the fever's been going on for a few days, that they could potentially run this test and be able to see if there's a high likelihood for Kawasaki disease. So we're going to switch a little bit to the issue of therapy. As you all know, our standard therapy right now is high-dose intravenous immunoglobulin. And the reason we use this therapy is that it reduces the risk of coronary artery abnormalities from 25% to 3 to 5% if a child is treated in the first 10 days of illness. You also know that your children were treated with aspirin during their course of illness. Now, a particular interest of mine are children that have had Kawasaki disease and receive IVIG. Their fever may go down, but then their fever recurs. And this is called intravenous immunoglobulin resistance, or IVIG resistance. And the definition is based on the recognition that fever is a very sensitive indicator of persistent inflammation, and that it's recurrence of fever a few hours following the end of the IVIG infusion that really defines your child as having IVIG-resistant Kawasaki disease. And what's crucial to remember is that these children that have IVIG-resistant KD are at a higher likelihood of having coronary artery abnormalities. That's been shown by our group and others. So I've spoken to a few of you already this morning about this issue that we have here in San Diego and that we're seeing also in Japan and other places in the world with Kawasaki disease. I'll orient you to this slide. Here on the y-axis, you have the number of KD patients. Here we have years along the x-axis. The yellow bars are the number of patients that are responsive to IVIG, and the red bars are those that are IVIG resistant. And then you have the percentages. And if you look across the board here, up until about 2005, in San Diego County, we had an average of between 10 and 20% of our patients that were resistant to therapy. This has been the reported percentage that's happened worldwide. In 2006, what was frightening to us was that this red bar shot up to about 38%. And to this day, unfortunately, we don't know why this happened. We've had a number of investigations with even the pharmaceutical company that makes IVIG to try to figure out exactly what this was. Was it a difference in the way the product was made, a difference in the patient? None of those have panned out. But what we're left with, we have had the percentage of children that are resistant therapy come back down over the last couple years, but it's still quite high in the 20% range. And our fear is that for some unknown reason, and because we don't know what causes KD, it's hard to determine exactly what it is, but for some unknown reason there may be a group of children that are now more resistant to therapy than they used to be. And this has made us very interested here in trying to find additional therapies, both for children who are resistant to IVIG, but also, and I'll speak to you in a moment about our infliximab trial, to try to find additional therapies for all children with Kawasaki disease in order to prevent this percentage from rising any further. So what therapies do you have? And many of your own children may have received these additional therapies. We can always give a second dose of IVIG. I'll talk to you a little bit about infliximab in a moment. Steroids and cyclosporin. These are all drugs that we use in children that are resistant to therapy, and also those with coronary artery aneurysms that need to have the inflammation brought down. So what is infliximab and Remicade? So this is a TNF-alpha, tumor necrosis factor alpha here, is a molecule that's made by the body.